So my objective today is to convince you that this disease, Sjögren's disease, really may be one of the new therapeutic targets in rheumatology and internal medicine. And now we have arrived at the time where the treatments can begin in this disease. We have maybe 10 years behind lupus, and it was very interesting to compare where we are in lupus and when we are in Sjögren, and I'm going to show you in the minutes in this talk in this morning. So just a few slides for reminding you what is this strange disease. I don't like the private name for qualifying a disease, and the good name for this disease should be autoimmune epithelitis, because clearly the autoimmune process in this disease occurs around the epithelium. Is it a rare or frequent disease? Nobody knows. You see that the range is very large. So in some studies it's very rare, in others it's not. What is sure, it is more frequent than lupus, and the true frequency could be between both, between 0.05% of the general population. 9 women for 1 man, and as you know, it is also a paradigm of the associate autoimmune disease, because Sjögren may be primary but may be also associated with other connective tissue disease. I don't like the term secondary too, because in most of these cases, associated Sjögrens, the course of associated Sjögren is exactly the same as the course of primary Sjögrens, except for rheumatoid arthritis. But in lupus, dermatomyositis, scleroderma, the course is the same. So you all know the classical symptoms of the disease. They are very common in the general population: dryness, fatigue, and pain. And these symptoms are very disturbing for the patient, and the quality of life of the patient is very poor. You see the dryness here. And of course, as these symptoms are very frequent in the general population, we need some criteria for defining the autoimmune disease, which is Sjögren's disease. And these criteria exist now since 2002. And you see you have 4 of these criteria, but it's mandatory to have the proof of an autoimmune injury, which is anti-SSA or anti-SSB antibody, or a nodular infiltrate of the salivary glands. Here, the focus, you see here, two foci in this salivary gland biopsy. There is now a debate about the criteria. It's not a very interesting debate, but don't be worried about that. American colleagues decided to set up new criteria, because NIH decided that and required that for giving a grant to a big group headed by the Californian colleagues, Lindsay Criswell in California. So we have now this new preliminary ACR criteria, and actually they are very close to the American-European consensus criteria. You see 2 out of the 3 items on the top: autoantibody, focus score, and OSS, which is ocular staining score. And if you compare this ACR criteria, preliminary ACR, to AECG, you see they are very, very close concerning both sensitivity and specificity. So it was really a pity to have 2 sets of criteria. So we decided, American colleagues and European, to go together, and we are building now a consensus EULAR ACR criteria, which will be ready at the end of the year and which will be very close to AECG or preliminary ACR criteria. So this war of criteria will not occur, and now let's move to more interesting things, which is the pathophysiology of this disease and the new treatments of the disease. So you see that this disease, you have 1/3 of the patients without any anti-SSA, anti-SSB, and by definition, you must have at least a focus score on the biopsy in these patients. We have 1/3 of the patients with anti-SSA alone, and the other third with SSA plus SSB, because you never have SSB without SSA. It is always a spreading from SSA alone to SSA plus SSB, and it is very interesting from an immunological point of view. So the serious complication of the disease exists, and it is a problem of this disease. You see very various neurological, pulmonary, bronchial, interstitial nephritis, not glomerulonephritis, except if you have cryo, lymphoma, I will speak again, renal, purpura, synovitis, and parotid enlargement. And in real life, it's very difficult to differentiate parotid enlargement from benign from lymphoma, because most of the lymphoma occur at the site of the disease, of the autoimmune disease, in salivary glands. So let's move now to the different treatments, the new treatments of this disease. And I will begin by what we did now 15 years ago in France at the time where anti-TNF went to the market for RA. We were in 2000, and in 2000 we thought that anti-TNF could work in every systemic inflammatory disease. And we did this trial in Sjögrens and randomized infliximab versus placebo. We may find some reason for that. There is always reasons for doing anti-TNF in every disease. And if you remember well, when we began anti-TNF in spondyloarthritis, there was no really rationale on that. And finally, the drug was so efficient in spondyloarthritis. So we did that, and we assessed the patients at 12 weeks and 22 weeks, and we assessed the patients. We didn't have any outcome at that time. So we were very pragmatic. We wanted the patients to be improved in dryness and to be improved in fatigue and in pain. So we have an outcome 30% improvement in 2 of these 3 VAS. We calculated we will have 20% of placebo effect, and we were not too bad because we had 26% of success in placebo arm. But in the infliximab arm, it was exactly the same. So infliximab doesn't work in this population of patients with classical Sjögren. At the same time, there was in the US a study with etanercept, randomized controlled trial, and it was exactly the same result. It was negative. But the American colleagues were smarter than we were, and they tried to understand why anti-TNF didn't work. And they looked at different cytokines, and especially interferon, type 1 interferon, and you can see here, and the BAFF serum in the patients. And you can see that anti-TNF increases interferon and increases the BAFF level, whereas placebo has no effect. So based on that, this axis could be proposed as one of the pathogenic axes in Sjögrens disease, the type 1 or type 2 interferon, the increase in BAFF or BLYS, and the activation of the B cells. So what are the arguments for the involvement of these actors in pathophysiology of the disease? First, we found in 2006 now, 10 years ago, an interferon signature in the salivary glands of the patients. You can see here that among the genes which are overexpressed, most of them, a lot of genes are interferon-driven. And among the genes which are underexpressed, you have SOX3, which is a controller of type 1 interferon. Moreover, we found in this work the presence of PDC, plasmacytoid dendritic cells, within the salivary glands, and PDC, as you know, are the professional cells secreting type 1 interferon. The type 1 interferon signature was also found in the peripheral blood by the Oklahoma group, exactly like in lupus patients, and especially in the patients with autoantibodies. And last, we had last year the first GWAS analysis in Sjögren's patients, and it is a big group from different continents. It is coordinated by Kathy Civil-Moser in Oklahoma. And among the genes which are associated with the disease, you have 7 genes. You have HLA, but you have IL-5. And IL-5 is a gene which is really involved in the interferon pathway. And IL-5 polymorphism is also involved in lupus. We also found previously this association with IL-5 polymorphism in our patients. You see, it is this insertion which is more frequent in the patients with Sjögren. And interestingly, we found that this polymorphism was functional, because if you look at the salivary epithelial cells, we can culture salivary epithelial cells, you can see that the level of IL-5 mRNA is different depending on the polymorphism. And if you stimulate these epithelial cells with poly-IC or with a virus, so you increase the difference in IL-5 mRNA depending on the polymorphism of IL-5. So why this interferon signature? Like in every autoimmune disease where interferon is involved, could it be some viruses? And of course, Sjögren occurs in the mouth, and the mouth is a garbage with number of microbes, bacteria, and viruses. And now for years we look for virus in this disease, but today we never found recurrently a virus really involved and associated with the disease. All this study was never replicated. So maybe instead of looking outside, maybe we should look inside. A great part of our genome is made of endogenous retroviral sequences. And these sequences usually are completely silenced, essentially by methylation. And sometimes they can be expressed. And it could be a very interesting avenue of research. And very recently we found some abnormalities of methylation in this disease. The paper has just been accepted by the Annals of Rheumatic Disease, especially in the B cells, more than in the T cells, and especially in the genes which are also the target of genetic polymorphism. So these genes could really be important. That's the first study, my first study in Sjögren now, a lot of time ago, I'm afraid when I see the date, but we looked at EBV, you see, within the salivary epithelial cells of this duct, which is completely dilated. So targeting type 1 interferon, we spoke of that in lupus, and it's exactly the same question in Sjögren. We spoke of that previously, but we have this old drug, this old guy, which is hydroxychloroquine, which is one of the bases of treatment of lupus. And you all know that Plaquenil works probably by an anti-interferon effect. It's probably by the inhibition of the fixation of immune complexes to TLR. And Plaquenil has been given in Sjögren, and until now without any RCT. So it only open studies, a small RCT here, and in open study it seems efficient. So we designed in France a randomized controlled trial of Plaquenil versus placebo in a cohort of 120 patients with Sjögren. Not severe Sjögren. Most of the patients only had dryness, pain, and fatigue. And it was recently published in the JAMA. The result is negative. The primary endpoint was the same as the previous one. It was the percentage of improvement of the 3VS, dryness, fatigue, and pain. And that's, I apologize, it is too small, but that sensitivity analysis with different, you see the primary endpoint here, completely negative. But sometimes you have, sometimes on the right, something. And it is always the pain VS. So Plaquenil has absolutely no effect on dryness and fatigue, but on the pain, I think it could have some effect. And if we had included patients with arthritis, true synovitis, maybe the results would have been different. But at least Plaquenil is not useful in all the patients with Sjögren. Type 1 interferon plays a role, but type 2 also plays a role. And type 2 was forgotten in the study about interferon in general in autoimmune diseases. You see this very nice paper from Anthony Rosen's group showing that some genes, it's very difficult to differentiate in a signature type 1 from type 2. And you imagine it's absolutely not the same. Type 2 is secreted by Th1, type 1 is secreted by a number of cells in response to a viral infection. So it's not the same mechanism at all. And some of the genes may be type 2, some may be type 1, and some type 2 genes are expressed in salivary glands of patients with Sjögren's. And again, looking at the GWAS, two of the genes in these GWAS are clearly associated with type 2, IL-12 and STAT4, which are rarely genes associated with type 2 interferon. And also, you see that STAT4 polymorphism has been replicated by other studies in Sjögren. So that's the mechanism of IL-12 and type 2 interferon. IL-12 binds the receptor, and there is a dimerization of STAT4, and this dimerization of STAT4 leads to type 2 interferon secretion. Recently, we published a paper showing that the cells which could secrete type 2 interferon could not be Th1, but could be also NK cells. NK cells were not studied a lot in autoimmune diseases, and we started from genetic again. We found polymorphism of the promoter of NCR3 coding for NKp30, which is a specific protein of NK. And this polymorphism, you see, was protective, is here, protective of Sjögren compared with control. And after we looked at the NK cells of Sjögren's patients, and in the Sjögren's patient, effectively we found an increased level of NKp30, this NK protein coded by this gene. And you see the increased level. And after we looked at the glands, and we found the NK cells, you can see here in red, around the foci. So the NK cells are present in the foci. And there was a very good correlation between the percentage of NK cells and the focus score here. And last but not least, we found the ligand of NKp30, which is B7H6. We found this ligand in the epithelial cells of the salivary glands. So clearly there is a crosstalk between the salivary epithelial cells, which can express the ligand, and the NK cells, which can invade the glands. So type 1, type 2, and the second important actor is BAFF or BLYS. We spoke a lot of BAFF or BLYS, so I will go very fast. In this room, you all know that BAFF is not only a popcorn, so I go there. This is very interesting data about the BAFF transgenic mice. If you look at these mice, they rarely have the mice that develop first something looking like lupus, glomerulonephritis, and non-erosive polyarthritis. It's not a good model of array, these mice. After they have cellulitis, and after they develop lymphoma, exactly this, like the transition you may have in lupus and in Sjögren's patients. So our group and others found a number of arguments suggesting that BAFF is involved in this disease. And you can see here the increase in the serum level, the correlation with rheumatoid factor, the presence of T cells expressing BAFF. And here, the demonstration, now it is well admitted, but at that time it was not, that BAFF is a type 1 interferon-induced cytokine. And you can see the salivary epithelial cells here. When you stimulate with interferon, these epithelial cells may secrete the BAFF cytokine. So how inhibiting BAFF, you all know that, so I go very fast. So belimumab today is the most used way of inhibiting BAFF. You all know this result in lupus, this small difference, but this small difference leading to the approval of the drug in lupus. So we designed the first open phase 2 study of belimumab in Sjögren's. Unfortunately, it is an open study. It's not a randomized control study because at that time the lab didn't want to have a placebo arm. And what did we see? We did the study in 2 sites, in Paris and in Udine with Salvatore Di Vita in Italy. And you see that 60% of the patients were considered responder, where the response was defined by improvement in 2 of these 3 domains. And the most interesting in this study is that most of the patients with parotid swelling improved with belimumab. And I think it is an interesting thing to see in this study. The B cells may be activated by BAFF, but may be also activated by IL-6. We spoke of IL-6, and very interestingly, in Sjögren, IL-6 may be induced by BAFF. It has been shown by a Japanese colleague. If you take the monocytes of Sjögren's patients and you stimulate the monocyte with BAFF, you induce IL-6. And if you do the same with controls, you don't induce IL-6. And that's interesting because IL-6 could be a target. And we have currently in progress in France a randomized control trial in Sjögren's with tocilizumab. We have included 40 patients, 120 have to be included, so we'll see what anti-IL-6 can do in this disease. Like the B cells, and Sjögren's is certainly the autoimmune disease where the B cells are the most activated. You all know that it is the autoimmune disease when you can have a huge level of polyclonal immunoglobulin, 30, 40, 50 grams per liters of immunoglobulin, increase in serum light chain, increase in beta-2 microglobulin, which is also a marker of B-cell activation. BAFF, we spoke about that. And there is a good correlation between some B-cell biomarkers and the clinical activity of the disease. I will come back on SDI. And last, you all know that in this disease, it is also the autoimmune disease where the risk of lymphoma is the most important. And it's clinically difficult to distinguish these patients with polyclonal B-cell activation from these patients with B-cell lymphoma. These B-cell lymphoma occur in 5 to 10% of the patients with Sjögren. They occur at the site of the autoimmune disease in the salivary glands. So not surprisingly, most of them are mild lymphoma, mucosis-associated lymphoid tissue, which belong to marginal zone lymphoma, but they can transform into a diffuse large B-cell lymphoma. And now we work on that in the lab on the reason why these autoimmune B cells may escape and become lymphomatous, because it's now demonstrated that it is the autoimmune B cells themselves will become lymphomatous, but I don't have time to develop that point. So B cells are activated in the disease. Of course, rituximab could be a drug, interesting drug. The Dutch people did the first study, 30 patients, all on TSSA, all biopsy with a focus. So rituximab plus steroid versus placebo. It was a randomized control trial. And the primary endpoint was achieved. It was on the stimulated salivary flow. You see the rituximab here and the placebo, and you also see that the symptoms were also improved in rituximab versus placebo, the VS oral dryness and eye dryness here. Moreover, it's not a surprise that they also had a decrease in rheumatoid factor in rituximab versus placebo, as you can see here. So in France, we also ran a randomized control trial with more patients, 120 patients. It was head by this guy, Alain Sarraut, in Brest, at the west of France, the closest to your country. And the design was very simple. Rituximab at the rheumatoid arthritis dosage, 1 gram twice versus placebo. And at that time, we did not have still good outcome measures. So again, it was very pragmatic. Again, some VS, and it is a decrease of 30 millimeters. It's a lot, not 30%. Out of 2 of these 4 VS, pain, dryness, fatigue, and global disease, but assessed by the patients and not by the physicians. So the patients are there. They were well balanced between both groups, and the results were published in Annals of Internal Medicine, and the study is again negative. Here, the result at 6 months, you see the difference between both groups, absolutely no difference, but there was some differences in some outcomes. Look at the fatigue VS, look at the dryness here VS, and look at also some of the outcomes and the salivary flow, for example. Some of them could be clearly different, and especially the fatigue and the dryness, but not the pain, not at all the pain, absolutely no difference. And if we have looked at week 6, and not at month 6, the study would have been positive. There was an effect of rituximab which is very early and which tends to disappear after. That's very interesting. Maybe in this disease we should have more anti-CD20 on another type of anti-CD20. But so this study is negative, but clearly it doesn't. There were some hopes about new approaches with anti-B cell therapy. Look at the VS. Look at the fatigue. There is clearly a difference between placebo and between rituximab. The dryness is the same, and for the pain, it's not evident between both drugs. So that's the conclusion of STEERS. I spoke of that previously, but very interestingly, exactly a study with the same design has been conducted in UK by Simon Bowman, and now the patients have been all included, and we will have the data at the end of the year. And it will be very interesting to compare and to do a meta-analysis of both studies with rituximab in Sjögren's. There is this study of rituximab in Italy. It is not an RCT, it's a comparison between different centers using rituximab, because now, even if it is not licensed, in Europe at least, we use rituximab in some patients with severe complications. And usually the centers not using rituximab, but it is a marvelous curve, but be very cautious. It's not an RCT. It is just a comparison between different types of treatments, but clearly there is a benefit of rituximab, and they even show that with rituximab, there was a decrease in the focus score and no decrease with the classical drugs, as you can see here. Before leaving rituximab, I just want to say that rituximab, there is a specific complication for which you have to use rituximab. It is cryo. Rituximab works in cryo, and you know that the most frequent systemic disease associated with cryo after Hep C is Sjögren's. And look at this study we published in our register in France of patients with rituximab. You can see the patients here with peripheral neuropathy. The patients with cryo, it is this group, group 1. Almost all of them responded to rituximab. And when you have neuropathy without cryo, neuropathy, pure sensory neuropathy, rituximab doesn't work. Interestingly, rituximab induces an increase in the BAFF level. It's now well known in all the diseases where rituximab has been used. The serum BAFF level increased, but not only the serum BAFF level, but also the mRNA BAFF increase. Look at these patients, these single patients. The mRNA increased very early, and the serum BAFF after. So why not combining rituximab and belimumab? And it is something we have in mind. And so if we see that, the logic would be to give belimumab after rituximab. But you also know that with belimumab, you have at 1 month an increase in memory B cells in the blood. like if the memory B cells could drop in the blood just 1 month after belimumab. So it could be also interesting to give rituximab just at that time. So belimumab, rituximab, and belimumab could be an appealing strategy. And some companies are thinking about that, and GSK, for example, is preparing an RCT with this type of design, the combination of belimumab and rituximab in Sjögren. In the mouse, there are very interesting data by combination, both. I don't have time to show the data, but I never saw a decrease in anti-ribonuclear proteins with any B-cell targeted therapy, except with this combination in the mouse in a recently published paper in NR. CD22 is a target also, and you know epithelial is in a study in lupus, and there was this open study now 8 years ago, and it seems interesting, the improvement, the percentage improvement of each of these items, but it was open, so we have to wait. But UCB is planning to do an RCT of epithelial in Sjögren. You know that epithelial leads to partial depletion of B cells. Last but not least, the germinal center is a very interesting target in this disease. In 15 to 20% of the patients, you may have ectopic germinal center in the salivary glands, and these germinal center are very important because they are predictive of the risk of lymphoma. So they are associated with activity of the disease. So all the cells and the cytokines present in germinal center could be a target. And of course, the T follicular helper cells are very interesting. So they express CCXR5, ICOS ligand, or ICOS, they secrete IL-21. And today there are some reflections, there was a protocol by MedImmune of an anti-ICOS ligand, which is going to begin in Sjögren next month. And there are some reflections about anti-IL-21 or anti-CD40 or fertilizer. Last, before finishing, for doing new trials in this disease, and you have seen there is some ideas, and there are some trials which are beginning now, we have to have good outcome measures. So it was absolutely crucial to be able to measure activity of the disease, and this work was done by a group from EULAR, you can see that, and so we decided to set up 2 different scores. One score for the symptomatic features, which is a PRO, and this score has been called ESPRI, and one score for assessing systemic complication of the disease, and this score has been called SDI, as you can see here. So SDI is a mix between SLEDAI and BILAG, because we have 12 domains, but not one or no, like for SLEDAI, and not as complicated as BILAG. So you have different level of activity for each domain, and you have a weight which has been calculated. There is a development cohort and a validation cohort, and all the work has been done by this group, one of my collaborators, who is Raphaël Serror. ESPRI is a PRO, and ESPRI is very, very simple, because we started from 64 questions made by the patients, and at the end of the day, we arrived on 3 VS, which are very close to the VS which were used before. A VS which of dryness, VS of fatigue, and VS of pain. So the conclusion of pathophysiology is something like that. In this scheme, BAFF is at the middle, but you can put the cytokine you prefer at the middle. But what is sure is that there is something which is an environment target which can induce type 1 interferon, which plays a role. It can be also endogenous genes. Type 1 interferon stimulates BAFF, and you have a stimulation of MDC, NK cells and Th1 secrete type 2 interferon. The B cells are stimulated. The follicular T follicular helper are very important in the germinal center. You have this antibody against SSI, SSB, immune complexes, and the vicious circle, etc. So to conclude, a lot of similarities between Sjögren's and lupus, same interferon signature, same genetic predisposition, same involvement of BAFF, and I think we could call Sjögren's lupus of mucosa, and now it could be very important to work on what is the role of mucosa for driving this disease in mucosa rather than in lymph nodes on the spleen. And the current targets to be explored, the 2 types of interferon, BAFF, of course, the IL-12, IL-6 B cells, follicular helper cells, and very important. I didn't have time to speak of that, but plasma cells are very important in the biopsies. And plasma cells and all the work with bortezomib in lupus, I think, also should be thought what we could do in Sjögren with this type of plasma cell depleting drugs. And like usual, the new treatment will come from new pathogenic concept. I would like just to analyze all my groups in the lab and also in the clinics and the grants we got and all the collaboration we have in Europe and in the US for doing all this type of work. Thank you very much for your kind invitation.